thank you for the organizer to let me have the time to share our recent research working on the enterovirus and infection and looking for the genetic cause for severe virus infection. I want to just mention this is the iceberg when I visit a conference. I like this picture because I want to show you that maybe the thing we think, the fact is more complicated than we think. Why I mention that? Because as you know, enterovirus for me, the most interesting part is not the infection, is that when we get infection, most of the patient individual exposed to virus was symptomatic. And gradually, some have so-called foot and mouth symptoms, and most very rare condition, they have very severe infection involve the CNS. However, if you think about severity, gradual difference, but the frequency is much less and less. So the problem is, for me, the most important question is why this rare patient will suffer from such severe infection. For me, it's most important question. So as we already discussed today, that a lot of study has been done in the virus itself. Generally, it's very difficult to say that certain mutation is associated with almost 100% linked to very severe infection. So it's less unlikely the virus itself causes such severe infection, including the genotype variants. So the other possibility, if it is a problem of the host instead of the virus, this is our working hypothesis. So in fact, it has been shown in a very, very good case is the HSV. As we know, HSV infection is almost happening in 95% individual. However, in very rare, almost 1 in 100,000 cases, the very mild HSV infection can cause very severe encephalitis, but for one reason is unknown. Until 2007 and 2007, Dr. Cheng-Lung Ku and Dr. Shang had published paper on Science. After 7 years ago, published paper in the neurology. They show that severe HSV infection, encephalitis may be caused by the toll-like receptor deficiency. Due to a time limit, we have no time to discuss toll-like receptor 3. But just to let you know, toll-like receptor 3 is the innate receptor expressed ubiquity in most of the tissue, and it can sense the double-strand RNA. So in the paper, they demonstrate that in a patient, if you stimulate with the poly-IC, in fact, it's the toll-like receptor, a synthetic ligand. The patient, if you have the mutation, you have shown no response to the poly-IC stimulation. Indicate there are really loss of function in toll-like receptor 3, and the patient suffer from very severe HSV. And after that, after 10 years working, very interestingly, Cheng-Lung Ku and consequent report a series of mutation. And if you link the mutation together, it becomes a very interesting story is that this is the toll-like receptor 3. And the mutation in its downstream molecule, including UNC93, 93P, TRIF3, TPK1, even the transcription factor IRF3. The mutant of this gene, the patient will suffer from severe HSV encephalitis. It indicates the toll-like receptor 3 is critical to control HSV infection in CNS condition. So it may be very interesting if we compare with HSV and EV71 infection. In fact, EV71 infection will affect most of the child. It's very easy to diffuse, and like HSV. However, most of the infections are symptomatic or very mild. And just in very, very rare conditions, they have encephalitis. So they are both are viral infection, high prevalence, but make severe case in very, very rare conditions. And both of them are CNS involved. So we are thinking about if it's possible the toll-like receptor 3 play a critical role to control a severe enterovirus infection. So we have got the first child is a 5-year-old boy, and generally he has stage 2 to stage 3. Encephalitis, and he recovered without sequel, and all the immune parameter is normal. So we take patient's blood and we activate the patient with different virus, including HSV, Enterovirus. The patient PBMC responds totally normal, and the patient with toll-like receptor 3 deficiency. But interestingly, when we take the patient's fibroblast, you can show that this is toll-like receptor 3 deficiency with HSV encephalitis. This is our patient. When you stimulate with poly-IC, the patient shows severe impaired response, and this response in the 18-hour, 14-hour, and until 2 days, the patient response still mild compared with the control. And if we see the interferon production, fibroblast production, interferon beta or interferon lambda, mean IL-29, the patient show a delayed, a weak response stimulated by the poly-IgG. It seems that the patient also suffers from a mild form toll-like receptor 3 deficiency. So we also use the patient's fibroblast to test his susceptibility to the virus. You can see that when we use the HSV-1, we know that toll-like receptor 3 deficient and this downstream molecule deficiency fibroblast is sensitive to the HSV infection induced cell death. And this is control, this is the 3 mutant. And our patient show exactly the patient like the other toll-like receptor deficiency. And when we think about the EV71, it's the same. Toll-like receptor 3 deficient fibroblast show a defect, show a susceptibility to the EV71 induced cell death, and also our patient. So, and A16, but there's no difference in CDB3. So we are thinking about we have the sufficient data to suggest patient maybe suffer from toll-like receptor 3 deficiency. Then we looking at sequence the toll-like receptor 3. In the patient, we find a heterozygous mutation in the toll-like receptor 3, W769 become a stop codon mutation. So this is the mutation was in the intracellular domain. So in fact, it can truncate the signal transduction in toll-like receptor 3. So since we have only one case, it's difficult to convince doctors. So we sequence around 150 patients with at least a stage 2 enterovirus infection. In more than 100 cases, we found 2 other patients. He has a mutation in E211K, and the others are A67Q. So interestingly, this is when we think about his CAT score and the frequency. Our patient, first one, he carried a very, very rare and a high CAT score, means possible disease-caused mutation. Patient 2 even is also a very extremely rare mutation, however, its CAT score is very low. And when mutant 3, in fact, the mutant 3, this mutation even is high frequency. However, this mutant has been shown to cause the HSV infection in patients. So this is a real disease-caused mutation. So to prove that because the third mutation has been shown to its disease-caused mutant, so we try to validate the patient 1 to patient 2 the mutation. So we do a functional assay. We transfect the mutant toll-like receptor 3 in the cell line to check their function. You can see that when the wild mice, the cell line transfection toll-like receptor 3, it has very good response after the poly-IC stimulation. Our 2 mutation, the mutation of patient 2, E211K, and the mutation for the patient 1, W769X, both of mutants are totally loss of function mutation, indicate these 2 mutants have a lot of biological impact. So I think this is our finding. I think we just want, due to the time, I just want to discuss that. We think about that maybe toll-like receptor 3 mutant is very crucial to help the CNS system against the enterovirus infection. So if you have toll-like receptor 3 mutant, maybe the virus can successfully to invade your CNS system. So I think this is the case only to show that rare severe infection maybe not due to the virus itself, maybe can caused by the host deficiency in innate immune system. So I want to thank the people in the lab, particularly Mr. Luo. He do almost all the experiments, and Dr. Guo Zhenyan to help to the patient recruitment. And also we need to thank Dr. Lin Zhouyan and Dr. Zhang Luanying to provide the idea and give me a sample to the patient 2 and patient 3. And we think about Dr. Cheng-Lung Ku to the functional assay validation, help, and the board rating to provide the material for this study. And thank you for your attention.